Hi everyone. Let me start by thanking the organizers for this opportunity to lecture you on inborn errors of metabolism. I am Dr. Satekge. I'm a chemical pathologist. I work for the National Health Laboratory Service based at the University of Limpopo in South Africa. So this is the outline of the lecture. So let me start by saying that the lecture is long. It's quite complex. So it comprises of pathways, enzymes, cofactors, and you do have to grasp those pathways in order to understand the condition's pathophysiology, clinical presentation, as well as how we investigate for these conditions in the laboratory. So that's what we'll be covering. So let's start then. Inborn errors of metabolism, also known as inherited metabolic diseases. Individually, they are rare, but as a collective, they can be quite common. So the incidence range from 1 in 800 to 1 in 5,000. So this really depends on the test scope of specific countries. Obviously, the wider scope you test for, then the incidence will be higher, as you'll be detecting patients with these conditions. Over 250 inborn errors of metabolism have been discovered thus far. What is interesting is that more diseases continue to be discovered with research through metabolomics as well as genomics. So most of these conditions are inherited in an autosomal recessive fashion. So according to the Mendelian inheritance patterns, so it means that there's a 50% chance that offspring will be carriers, and there's 25% chance that the offspring will be affected, or 1 in 4 chance of the offspring being affected. So remember that for autosomal recessive inheritance pattern, you need to inherit defective genes from both parents in order for the disease to manifest in an individual. Some inborn errors of metabolism can be inherited in an X-linked recessive fashion, and some do get inherited as through the mitochondrial DNA. And remember that the mitochondrial DNA is passed through from only the mother. Very few inborn errors of metabolism can be inherited as autosomal dominant disorders. So with regard to presentation, they tend to present early in infancy, but some can present in late childhood or adulthood. So in cases where there's residual enzyme activity, then it can present in late childhood or adulthood, and these tend to be milder compared to when you present in early infancy with severe disease as a result of undetectable or enzyme or complete enzyme deficiency. So these are the mechanisms of how inborn errors of metabolism arise. So essentially, we have these are monogenic disorders whereby there's a mutation in a specific gene resulting in impaired activity of enzymes or transporters. So in the case of an enzyme, how it works is that you will have a metabolic block because of a certain enzyme deficiency, and this will result in accumulation of substrates, and these substrates undergo alternative metabolism, resulting in accumulation of byproducts, which we refer to as metabolites that we can measure in the laboratory. Also, as this block, you can also get decreased formation of essential products, also resulting in consequences to the patient. So there's 3 mechanisms that inborn errors of metabolism can arise. So this is also a classification. So the first one is the intoxication effect. So this tend to present early, within 24 to 72 hours of birth, or more specifically after the baby is been presented with feeds, 24 to 72 hours after feeding. It presents with acute presentation due due to accumulation of the substrate. These are the abnormal metabolites. So, for example, here would be organic acidemia or even aminoacidopathies. Energy deficiency is another mechanism. So these patients tend to be asymptomatic for a long time until they get met with a stressful event, for example, like infection or patient going surgery, or just by fasting. Then the patients will have the clinical manifestations. Due to this increased energy requirements, presenting as a precipitant to the condition. So an example here would be fatty acid oxidation disorders. Disorders of complex molecules. So these are defects in synthesis or catabolism of complex molecules. So this degradation of these complex molecules happens in the lysosomes or the peroxisomes. So there's a progressive presentation that is independent of intercurrent events. So what we are saying here, it's independent of whether the patient is having fits or not, or being exposed to certain fits. An example here would be lysosomal storage disease or peroxisomal disorders. So let me start by going through carbohydrates inborn errors of metabolism. So, but before then, I'll just give you a summary of the of metabolism that happens in the body. So, essentially, to generate energy, we make use of fats or lipids, carbohydrates, and proteins. These are the important sources of energy, or source of energy for the body. Okay, so let's start with carbohydrates. So carbohydrates here, remember that glycogen is the stored form of glucose. So in a fat state, okay, so the glucose will be converted to glycogen to be stored in the liver, okay, through glycogenesis. Glycogenolysis occurs when there's a period of starvation, whereby we break down the glycogen to generate glucose for the cells. So what is the effect of glucose after it has been made available in the blood? It is taken by the cells as glucose 6-phosphate, and it undergoes glycolysis to generate pyruvate and to generate acetyl-CoA. So lipids and fats metabolism also generates quite a high amount of acetyl-CoA compared to glycolysis. And also protein and amino acids, they also generate acetyl-CoA. So already from here, you can see that the common substrate of all these pathways, these metabolic pathways, is generation of acetyl-CoA, which then goes to the TCA cycle or Krebs cycle, which then also feeds into the electron transport chain to generate the energy that the body needs. So that is essentially the summary of metabolism from the food that we digest. Importantly is the protein and amino acids. So they give rise to what we call nitrogen pool or amino pool. Remember that amino acids, they contain a keto group as well as an amino group. Now, the amination of the amino group generates ammonia. Do you know that ammonia is toxic? So it needs to be detoxified. So it is detoxified by a process called urea cycle to generate urea, which can be excreted in the kidneys. So we'll be discussing in detail the urea cycle as we go into the lecture. So let's tackle now the glucose metabolism. So on the left here, we'll speak about glycolysis. This is a common pathway. It's a pathway that you're supposed to be familiar with. So it's quite a lengthy pathway. So probably the important aspects of glycolysis to consider will be the rate limiting steps. Okay, so the rate limiting steps, they are catalyzed by which enzymes? So it's catalyzed by 3 enzymes. The first one here is hexokinase. Second one is phosphofructokinase 1. The last one is pyruvate kinase. So these are the rate limiting steps of glycolysis. So why are they important? You notice that when you talk about gluconeogenesis, most of these pathways, most of these reactions, they are reversible, except the rate limiting steps, as you can see. No, not reversible. So that is why these rate limiting steps, they are important. But they are also important in the context of gluconeogenesis. Gluconeogenesis, by definition, is the formation of glucose by non-carbohydrate sources. Okay. So what are these sources? These sources include amino acids. They include triglycerides in the form of glycerol. They also include lactic acid in the form of Thoracic. So gluconeogenesis is not the reverse of glycolysis. Why? Because of this rate limiting steps. So what it means essentially is that if you have to undergo gluconeogenesis, you need new enzymes to replace these rate limiting steps enzymes. Okay. For example, your pyruvate kinase, you need pyruvate carboxylase, phosphoenol pyruvate carboxykinase, phosphokinase 1, you need a new enzyme here, fructose 1,6 biphosphatase, and glucose 6 phosphatase in place of hexokinase. So that is why these rate limiting steps, they are important. Right, so now we'll go to glycogen metabolism. Okay, so this is a very, very simplified diagram of glycogen metabolism. Okay, so in a fat state, we want to convert glucose into glycogen. So the enzyme responsible for this is glycogen synthase. And then in a fasted state, you need to break down glycogen to generate glucose. The enzyme there is glycogen phosphorylase. So this is an enzyme that breaks down the glycogen. So what is important about these enzymes is where they act. Okay, so they act on the alpha 1 4 glycosidic bond. So that glycosidic bond is what is important to make complex sugars. Okay, for example, glycogen. So in this case, then this glycogen synthase will create the alpha 1 4 glycosidic bond, while glycogen phosphorylate will break it down to generate glucose. Okay. So there's also other steps that are involved. The last of which is glucose 6 phosphatase to generate glucose. The other step is also present there in gluconeogenesis. So this makes sure that there's enough glucose in the cells, in the blood, to be taken up by the cells to generate energy. Right. Speaking about glycogen, now we're going to discuss what glycogen storage disease. Okay. So unfortunately, there are many types of glycogen storage disease. There are about 11 types, but I don't think it's important to know all of them. The one that you have to know about is type 1. So this is type 1. What is a deficiency of glucose 6 phosphatase? Okay. There are others that we can talk about. For example, just to speak more about the glycogen metabolism, it also involves this enzyme here, debranching enzyme. So what's debranching enzyme? So this is the enzyme that breaks what? The alpha 1 6 glycosidic bond. Okay, so that's where branching happens to form glycogen. Okay, so debranching is when you're breaking it down to glucose, and then when you're forming glycogen, means there's branching, then it creates that alpha 1 6 glycosidic bond. Okay, so deficiency of this enzyme gives you type 4. Deficiency of this enzyme gives you type 3. The one that you also need to know something about is type 5, also known as McArdle disease. So what is interesting about this enzyme is that it is deficient, is enzyme deficiency of this one here, phosphorylase A, that is only present in the muscle. Okay, so when there's deficiency of this enzyme in the muscle, then it gives this type 5 McArdle disease, which presents with metabolic myopathy, only muscle involved. Another one just to know about is the type 3, also known as Pompe disease. This is where there's deficiency of this enzyme, which is only found in the lysosome. Okay, so therefore type 3 is classified as a glycogen storage disease as well as lysosomal storage disease. So this is just a diagram to show on the pathophysiology and the clinical presentation of the type 1 glycogen storage disease, also known as Phenylalanine disease. As we know, the deficiency is glucose 6-phosphatase. So in other words, we are unable to generate glucose from glucose 6-phosphate. And as a result, obviously, you're going to get hypoglycemia. But in addition to that, if we have glucose 6-phosphate that is being contained into the cell, so this becomes committed to undergo further metabolism. Okay, so most of which it will undergo glycolysis to generate pyruvate, but because we're generating a lot of pyruvate because of this accumulation here, some of the pyruvate, it gets converted to lactate or lactic acid. Okay, so this is through the anaerobic respiration, so it can generate lactic acidosis. In addition to that, from pyruvate, we generate a lot of acetyl-CoA. And remember that I mentioned that acetyl-CoA in excessive amount, it results in increased fatty acid synthesis or lipogenesis. So therefore, we're going to get accumulation of triglycerides or lipids in the liver, resulting in hepatosteatosis or liver disease. In addition to that, glucose 6-phosphate, it undergoes what they call the pentose phosphate pathway. This is through glucose 6-phosphate dehydrogenase, and the end product there is purine synthesis. Okay, this is part of the DNA synthesis. And remember, if you activate purine synthesis, okay, in excessive amount, you generate a lot of uric acid, resulting in hyperuricemia, which can also present as gout. So that is why this is how the glycogen storage disease manifests as the pathophysiology of why they get lactic acidosis, liver disease, as well as gout. So under carbohydrates metabolism, you also need to know how galactose is metabolized. Okay, so this is in the context of an important condition called galactosemia. So there are 3 enzymes that are involved in galactose metabolism. What are the enzymes? Galactokinase, GALT or GALT1-phosphate uryl transferase, the GALE, also known as UDP galactose 4 epimerase. Okay. So what is the normal metabolism of galactose? So it starts with galactokinase. Essentially what it does, it removes a phosphate from ATP to generate ADP. And then this phosphate is joined up with galactose to get galactose 1-phosphate. The next step is catalyzed by GALT. So GALT is a uridyl transferase. So basically it transfers the uridyl group. So then what it does, it combines UDP glucose with galactose 1-phosphate, so that the galactose 1-phosphate becomes glucose 1-phosphate, and then UDP glucose becomes UDP galactose. And then to complete the process is they get an epimerase, which simply converts galactose to glucose. But this can also be reversible. Okay, it can also go the other way. So the process of it going the other way, it has to do with a process called endogenous galactose production. Okay, so it happens through UDP glucose pyrophosphorylase. And what it does here, it generates this UDP galactose, which is what important function in cellular signaling, as well as cellular communication or detection. That is why patients that are not consuming milk, they're still able to make their own galactose for important cellular function. So what is important about galactosemia is that when you have a block either here or there, we get accumulation of galactose because it's not metabolized into the blood. So once this accumulates, it undergoes alternative metabolism, generating galactonic acid or galactonate, as well as galactitol. Now, this galactitol that gets deposited into the lens, okay, to give you cataract, which is an important clinical manifestation in galactosemia. But if we have the block here, okay, it means there's also accumulation of GALT1 phosphate. So GALT1 phosphate is highly toxic. So this is one that is responsible for the clinical complications of classical galactosemia due to GALT deficiency. So what is important about galactosemia is its clinical presentation. Also can refer to them as complications. So you would classify complications according to the acute in a neonatal period or the long-term diet-independent complications. So what is important about this complication is that they are diet-dependent. So what does that mean? It means that you need to treat early. Early treatment means what? Galactose restriction or lactose restriction. Okay. But what is also important is that these complications here, they can arise despite the patient being on galactose-free diet or not. Okay, so that will happen regardless. So that is why screening for galactosemia it is a bit of a contentious issue because some people argue that even if you detect it early, you treat early, you still develop some complications. But what is important is that the acute complications can be life-threatening. As you can see, they can cause brain edema, they can result in coma, hepatomegaly leading to liver failure. It also results in renal failure. So there's still an argument that galactosemia should be screened to detect early in the neonatal period to be able to prevent these acute complications, which can result in mortality. So looking at the I'll be sharing some chromatograms of some of these conditions. So this is the first chromatogram of a galactosemia patient. Okay, so important to note is this metabolite galactonic acid and galactitol. So once you have this present in high amount in the urine of an affected patient, these were able to make a diagnosis of galactosemia. So the other metabolites are highlighted here. So these they relate more to liver disease, not necessarily being specific for galactosemia. So this is a project that we've done for my MET. Okay, so basically we wanted to evaluate the screening of galactosemia at the lab where I did my training, University of Pretoria. Okay. So I'm not sure if you do screen for galactosemia in your country, but most of the developing countries they still make use of Benedict test and PLC, phenylalanine chromatography, to screen for galactosemia. So our objective in this research was to evaluate the performance of this screening methods for galactosemia. What were our findings? We found that the performance was inadequate because Benedict test and the TLC they had a number of false positive and false negative results. Okay, so in our recommendation, we're saying that if the Benedict test is negative or there's no galactose detected on the TLC, the baby should be given a trial of lactose, okay, and then repeat the testing. Okay, so this is in order to circumvent a false negative result. So with regards to false positivity, so the pathway that I mentioned here, the galactose metabolism pathway, it occurs in the liver. So then what does this mean? It means that if anyone has got liver pathology other than galactosemia, okay, there will be disruption of the pathway leading to galactosuria, meaning there will be galactose present in the urine, even though the patient does not have galactosemia. So this is what we call a false positive result. So that is all on carbohydrates, REMs. So the next section will be on aminoacidopathies or amino acid disorders. So I'll start this section by going through what we call the tyrosine pathway. Okay. So tyrosine pathway, it starts with an essential amino acid called phenylalanine. Okay. So phenylalanine and tyrosine, we refer to them as aromatic amino acids because they contain this ring called aromatic ring. So phenylalanine is converted to tyrosine via an enzyme called phenylalanine hydroxylase. Okay, so what essentially does, it adds an hydroxyl group. As you can see, the difference between phenylalanine and tyrosine, it is this hydroxyl group that gets added on the aromatic ring. Tyrosine is then broken down into 4-hydroxyphenyl pyruvate by an enzyme called tyrosine aminotransferase. This is converted to homogeneic acid by an enzyme called 4-hydroxyphenyl pyruvic acid dioxygenase. This is then broken down into malacetoacetic acid, okay, by an enzyme called homogeneous 1,2-dioxygenase. Then there is a spontaneous isomerization, giving rise to fumarate acetoacetic acid, which is broken down into fumarate and acetoacetate by an enzyme called fumarate acetoacetic acid hydrolase. So what is important about this pathway is the disorders that we get from this, from any defects of these enzymes. The first important condition that we get is phenylketonuria. Phenylketonuria results from a deficiency of this enzyme, phenylalanine hydroxylase. The rest of the conditions are tyrosinemias. Okay, so there are 3 types. Type 1, which is the severe one. Okay, it results from deficiency of fumarate acetoacetate hydrolase. And then type 2 occurs as a result of deficiency of this enzyme, tyrosine aminotransferase. And then 4-hydroxyphenyl pyruvate dioxygenase deficiency will give rise to type 3 tyrosinemia. So type 2 and type 3 are not mentioned here because they are rare and they are not life-threatening. So the one that you need to worry about is type 1. Okay. So what is important about type 1 is that it gives rise, when the blood comes here, accumulation of these metabolites, they give a compound called succinyl acetone. So succinyl acetone is a very important metabolite or compound that gives rise to the pathophysiology of this condition, of this severe condition. So in addition to that, you have to know something about galactosemia. This is as a result of a deficiency of the homogeneous 1,2-dioxygenase. Okay, so this one is not life-threatening. So what happens is that is accumulation of this acid here. So this acid accumulates where? In the connective tissues. So you see mainly in the ear, in the sclera, as well as most importantly in the joints. Okay, so in the joint, then what it tend to present with arthritis. So if you see a young patient presenting with arthritis, you must think of galactosemia. So in addition to that, when this acid becomes oxidized, it becomes black and becomes secreted in the urine. So some of these patients, what they have black substances in the diapers. Okay, then you must think of galactosemia. So although it's not life-threatening, there have been instances whereby some of this acid can be deposited into the heart, resulting in heart failure. But other than that, it's a harmless condition except for the debilitating joint pain. So Important conditions to know about is phenylketonuria. As I've mentioned, it occurs as a result of phenylalanine hydroxylase deficiency. It presents with microcephaly, complicated by intellectual disability, neurodevelopmental delay, and got this typical musty odor. So this musty odor occurs as a result of this phenyl pyruvate that is produced in excessive amount in the body. They tend to have hypopigmentation, presenting as fair skin and blue eyes. This is a result of melanin synthesis being affected by the block in the pathway. You also have chronic eczema. How you make a diagnosis? You make a diagnosis by measuring serum phenylalanine and tyrosine, okay, and then calculating the ratio. So remember that you make tyrosine from phenylalanine. So therefore, in these patients, because you have a block in the conversion of phenylalanine to tyrosine, you're going to have phenylalanine that is increased with the undetectable tyrosine. Therefore, the ratio will be increased. So this is how you are able to increase the sensitivity and the specificity of making a diagnosis compared to when you're measuring phenylalanine alone. You can also make a diagnosis by urine organic acid analysis. And what you're going to get, you're going to see phenyl pyruvate, phenyl lactate, as well as phenyl acetate. So this is a chromatogram of patient with phenylketonuria. So what do you see here? You see 3-phenyl lactate there. You also see 4-hydroxyphenyl acetic acid, 4-hydroxyphenyl lactate. So presence of this metabolized on a chromatogram is diagnostic of PKU. So how do you follow up these patients? So the treatment that you need to give here, you have to restrict phenylalanine. Okay, so that's how you treat these patients. So in their monitoring to check for compliance, you measure the phenylalanine as well as the tyrosine. Okay, so in these patients, you need to have the phenylalanine as low as possible in the blood. So that is your target for these patients. So in someone that is not compliant, the phenylalanine will be very high. So remember that I mentioned that you get tyrosine from phenylalanine. So it means that in this case, since you cannot make tyrosine, then tyrosine becomes an essential amino acid. So meaning that you have to supplement this patient with tyrosine, okay, and that is your target. Okay, at least there have been some adequate supplementation for this particular patient. But because of this non-compliance, because of the phenylalanine restriction, the phenylalanine tyrosine ratio will also not be within the target. Okay, so this also needs to be low. That is our target there, and this patient obviously is way above the target because of non-compliance. Tyrosinemia, I've already mentioned that the important one must know about is type 1, because this is the severe one, and is then also known as hepatorenal type. It presents with failure to thrive, diarrhea and vomiting, jaundice, cabbage-like odor. So this cabbage-like odor is a result of increased sectional acetone that is increased in large amount in these patients, which gives you this typical smell. You also get distended abdomen as a result of hepatomegaly. Okay, but you also know that they can also get acute liver failure or liver cirrhosis. Okay, and you know that with liver cirrhosis is often followed by hepatocellular carcinoma or hepatoma. So this patient also get acute porphyria-like picture. So this happens because sectional acetone, it inhibits an enzyme called aldehydratease. So aldehydratease is an enzyme in the heme synthesis. Okay, so that is why they get acute porphyria-like picture. They also get renal tubulopathy, okay, which can mimic Fanconi or proximal tubulopathy. How you make a diagnosis? Serum tyrosine is unreliable. Okay, so serum tyrosine is not always elevated in these patients, even though it's called tyrosinemia, but we do not measure the serum tyrosine levels to make a diagnosis. What do we measure to make a diagnosis? this sectional acetone. Okay, so you measure it in the urine as part of urine organic acid analysis. So the other types I mentioned that they are rare and not life-threatening. So these are the type 2. It occurs because of deficiency in tyrosine aminotransferase. So this it's also known as a gluconeogenesis type because it presents the photosensitivity as well as dermatitis. Type 3 is the neurological one. It presents with intellectual disability, seizures, loss of balance and coordination, and occurs as a result of deficiency of the 4-hydroxyphenylpyruvate dioxinase in the pathway. So that is all on aminoacidopathies. So the next section will be on organic acidemias. So in order to understand organic acidemias, we need to comprehend how branched chain amino acids are metabolized. Okay. So branched chain amino acids, these are also essential amino acids. So if you look at their structure, you'll see that they are branched. Okay. So what are these branched chain amino acids? There's 3 of them. There's leucine, isoleucine, and valine. Okay. So their metabolism is quite complex. So what you're going to concentrate on is where the arrows are. Okay. All right. But how is that? Is that with branch chain aminotransferase? So all amino acids, they are to start off their metabolism. Start with the transaminase. Okay. So this is a transaminase, branch chain transaminase or aminotransferase. That's part of the metabolism. As you can see, it's common for all 3 of them. Then it's followed by a decarboxylation step, okay, to generate this is what they call oxo acids. So this step is catalyzed by a very important enzyme called branch chain ketoacyl dehydrogenase. Okay, as you can also see, it's common to all to the 3 amino acids. Okay, why is this important? Because deficiency of this enzyme gives rise to a condition called maple serum urine disorder. Okay, so in the leucine pathway, there's also another enzyme called azoval-CoA dehydrogenase. Okay, deficiency of this enzyme gives isovaleric acidemia. That's another type of organic acidemia. Okay, and then common to the valine and isoleucine. Okay, you get this metabolite here called propionyl CoA. Okay, so this factor metabolized into methylmalonyl CoA by another important enzyme, okay, called propionyl CoA carboxylase. Okay, deficiency of this enzyme, it gives what we call propionic acidemia. Okay, so methylmalonyl CoA is metabolized into sectional CoA by another important enzyme called methylmalonyl CoA mutase. Deficiency of this enzyme, it gives what we call methylmalonic aciduria. Okay, so that is why branch chain amino acids is very, very important for these 4 conditions, which I'm going to speak more about in the next slide. So the first one is propionic acidemia. Okay, very, very important condition. Okay, it occurs as a result of deficiency of an enzyme called propionyl CoA carboxylase deficiency. Very important, biotin dependent. Okay, so some of these enzymes, they contain cofactors. Okay, so for example, the carboxylase is biotin dependent or misuse of biotin as a cofactor. Very important when it comes to treatment. How it presents? It presents with metabolic encephalopathy. So this is what we call a medical emergency, metabolic encephalopathy, which I will talk about later. Also present with bone marrow suppression, presenting as pancytopenia. So when you do basic investigation of these conditions, what you're going to see, you're going to see high NN-gap metabolic acidosis. This is a result of accumulation of propionic acid. Okay. which increases the iron gap. We also have ketosis, or presence of ketones, and hypoglycemia. Okay, and when you do an urine organic acid analysis, what you're going to find, you're going to find these key metabolites: 2-methyl citric acid, 3-hydroxypropionic acid, propionine glycine. So this is how the chromatogram will look like. Most important of this to note is 3-hydroxypropionic acid, propionine glycine, as well as 2-methyl citric acid. Okay, so these are key metabolites that will always be present when someone has propionic aciduria. So what is important about propionic acidemia is this concept called CoA trapping. Okay, so what is CoA trapping? CoA trapping is essentially you are removing a CoA from acetyl CoA. So in other words, since you are removing the CoA here, you are unable to form acetyl CoA anymore. Then you are forming what? The CoA, it is trapped by the propionic acid, generating what we call propionyl CoA. This is very, very, very important. Why? Because if you're unable to generate acetyl CoA, you cannot form citrate. Okay, and then citrate is how you get to the Krebs cycle. So in other words, Krebs cycle gets halted. Okay, gets disrupted. And know that when you disrupt the Krebs cycle, you are disrupting the body to generate energy. Okay, without Krebs cycle, there's no electron transport chain. Therefore, there's no ATP generation. That is why propionic acidemia can cause severe disease because of this CoA trapping, disrupting the Krebs cycle. But what's also very important is that if failure to form acetyl CoA, you form propionic CoA. So instead of citrate, they're going to form what? 2-methyl citrate. Okay. So how do you form 2-methyl citrate? It has to do with the structure. Okay. So the structure of acetyl CoA and propionyl CoA is exactly the same, except what? Extra carbon group on propionyl CoA. Okay. So acetyl CoA is 2 carbon long, propionyl CoA is 3 carbon long. 3 carbon long. Okay. And because you have an extra carbon, it will have an extra methyl group. Okay. That is why you are forming methyl citrate instead of citrate. Now, what is important about this CoA trapping is that it results in hyperammonemia. Okay, I'll explain later in the lecture why does hypoammonemia result. Hypoglycemia, I can tell you now how it occurs. It occurs because acetyl CoA is an allosteric activator of gluconeogenesis. Okay, allosteric activator of gluconeogenesis. So meaning that if you are unable to form acetyl CoA because it's been trapped, okay, you are unable to have gluconeogenesis. Therefore, we're going to have hypoglycemia. Very, very important. So the other types of organic acidemias, okay, so just know that it can present exactly the same. It can present exactly the same as propionic acidemia, okay. But what you need to know about that, the mutase, it makes use of vitamin B12 as a perfect, okay. Very important when it comes to treatment because you can supplement with B12 and then the patient can respond. How you make a diagnosis? You look for methyl citric acid and methyl malic acid on an urine organic acid analysis. Azovaleric acidemia, it can also present exactly the same as propionic acidemia when it comes to the presentation. But in addition to that, it is special in that it's called a typical smell. Okay, sweaty feet odor. Okay, so this is how azovaleric acid will smell like. Okay, so it occurs as a result of azovaleric CoA dehydrogenase deficiency. How you make a diagnosis? By looking at the presence of 3-hydroxyvaleric acid as well as azovaleric glycine. Another one also called triglycine may also be elevated. So maple syrup urine disease, this one is a bit of a misnomer because it falls under organic acidemias, but it's actually an aminoacidopathy because it results in high metabolism of the essential branch chain amino acids. But the way it presents, it resembles organic acidemia. Okay, so that is why, in terms of its presentation, it's also classified under organic acidemia. And also, we know that because of this metabolism of this amino acids, it generates most of the organic acid. They generate the organic acidemias. Okay, so that means it also it tends to allow MSAT to be classified as organic acidemia as well, especially with regards to how it presents. So I already mentioned the enzyme that gets deficient with this condition is the branch chain alpha ketoacid dehydrogenase. So this is a very large enzyme. Okay, it's a large enzyme that contains 3 subunits, of which are E1, E2, and E3. What is important about this E1 because it makes use of thymine pyrophosphate. In other words, it makes use of thymine as a cofactor. Very important. So it's called maple syrup urine disease because of the typical smell these patients smell like. Okay, so they have this odor, which some refer to as maple syrup. Some they describe it as burnt sugar. It also presents as metabolic encephalopathy because of this cerebral edema that results from increased leucine. So as you can see, among the branched amino acids, the one that is very toxic, neurotoxic, is the leucine. So this is the one that must have it in tight control in the body because that's what gives rise to the complications in maple syrup urine disease. How you make a diagnosis? The presence of allo-isoleucine, which is a form of amino acid. Okay, so when you do a serum amino acid profile, when you see this abnormal form of isoleucine or allo-isoleucine, is diagnostic and is specific for maple syrup urine disease. We can also make a diagnosis by branch chain oxo acids. Okay, so what is important about this condition is that high dose thymine supplementation can be used as treatment in some of these patients which are responsive, especially if the E1 supplement of the enzyme is being affected. So this is how a chromatogram will look like for MSET or maple syrup urine disease. Okay, so these are the oxo acids. So if we go back to the pathway, these are the metabolites that get just before the branch chain acyl keto dehydrogenase enzyme. So these are the metabolites that are, or the metabolites that are just upstream of the enzyme. Okay, so in the leucine pathway, there will be high amount of this metabolite there. Isoleucine, that's the metabolite, and then the valine, that's the metabolite that you're going to be found in high amount in the urine. That's part of the urine organic acid analysis. And also, when you also measure the serum amino acids, you're going to have a significant elevation of the branch chain amino acids because they are not able to be metabolized in the body. So this is the important concept of metabolic encephalopathy. So organic acidemia can result can present with what we call metabolic encephalopathy. So this occurs mainly as a result of hyperammonemia, okay? But it can also happen as a result of hypoglycemia, or as a result of the persistent metabolic acidosis, which can happen with organic acidemias. So this is a tragic and dramatic presentation in a baby that has been previously well, and they start to have become very sick after they've been introduced to the feeding. So the feeding will contain those amino acids that are toxic, okay, that are toxic to the organs or to the cells of the body. So what happens then? They refuse to feed, because it's the feeding, it's those metabolites that gets excreted through the feeds that makes them sick. So they get feeding intolerance, they get vomiting, they become irritable, failure to thrive because there's no feeding, they become lethargic, they can also have some apnea attack, seizures, complicated by brain edema, coma, and unfortunately death, if not picked up early. So that is what we call a metabolic crisis or a medical emergency, presenting as metabolic nephropathy, very dangerous because it can kill the patient. So this hyperammonemia, it can be high in organic acidemia, but it can also be high in urea cycle defects, which is what I'm going to talk about next. Now, when it comes to the urea cycle, it's also a bit complex, but not so much like the other pathways. So, the main purpose of urea cycle is to detoxify ammonia, to get rid of ammonia so it can make urea, which is water soluble and can be excreted. So how does it happen? So we have CO2 and ammonia coming together to form a compound called carbonyl phosphate. This is catalyzed by an enzyme called carbonyl phosphate synthetase 1. So then this follows by a reaction catalyzed by OTC or ornithine transcarbamylase. So this happens in the mitochondria. Okay. So essentially it takes the ornithine, okay, and then it combines with the carbonyl phosphate to generate citrulline. So it's taken into the cytoplasm. Then aspartate is introduced to the cycle to generate agenosuccinate. It is catalyzed by agenosuccinate synthetase. Agenosuccinate is broken down into arginine by an enzyme called agenosuccinase or agenosuccinate lyase, generating fumarate, which would go to the Krebs cycle. And then from arginine, we get ornithine by an enzyme called arginase, and that is where you generate the urea. Then ornithine is taken into the mitochondria and into the cytoplasm to start off the cycle. So what is important with urea cycle is the disorders. Okay. So we divide the disorders into proximal and distal. So the proximal one, they are the ones that occur before the citrulline formation. Okay. So they are characterized by low citrulline, while the distal ones, they occur after citrulline. Okay. So these are the distal ones. So they will result in high citrulline levels. Okay. So the two proximal disorders that you must know resulting in low citrulline are CPS1 deficiency and OTC deficiency. So the distal ones associated with high citrulline is they are due to agenosuccinate synthase deficiency, also known as citrullinemia type 1. So the next one is also agenosuccinase deficiency, okay, which present as agenosuccine aciduria. So these are the two distal conditions that we need to know about. So just to recap what I've just described. So basically the proximal defects and the distal defects. The proximal characterized by low citrulline. The conditions are CPS1 deficiency and OTC deficiency. Now, because the OTC block occurs after the formation of carbonyl phosphate, okay, so it results in accumulation of carbonyl phosphate, which is then is diverted into alternative pathway, which is the pyrimidine synthesis. And one of the byproducts that gets released with pyrimidine synthesis is urine orotic acid. So with this block, when we get accumulation of carbonyl phosphate, we get production of uric acid, which will be in excessive amount, and this is what you get in the urine organic acid profile. Okay. What is also important about OTC deficiency is the X-linked recessive disorder. Okay, and it's the only one that is X-linked recessive. The rest are autosomal recessive. So coming to distal effects, they are associated with high citrulline. So the first one is citrullinemia. We have got type 1, occurring as a result of agenosuccinate synthase deficiency. And then we've got type 2, which is caused by citrin deficiency. So now citrin is one of the transporters in the urea cycle. Okay. Agenosuccinate aciduria. Okay. So this is the one that occurs as a result of agenosuccinate deficiency, also known as agenosuccinate lyase. Okay. So in addition to high citrulline, it also has a high agenosuccinic acid, which is a diagnostic of the condition. So those are the distal effects. So this is a more detailed, more complex diagram of the urea cycle. Okay. So here I want to highlight a very critical step that you must be aware of. So the CPS1 enzyme, okay, for it to work, it requires an activator. So what is its activator? It's an acetyl glutamate. Okay, and how do you make it? You make it by combining acetyl-CoA with glutamate, and this is catalyzed by an enzyme called N-acetyl glutamate synthase to generate this important activator. So this will go back to the concept of CoA trapping, okay, which I mentioned in the propionic acidemia. Okay, so if you have CoA trapping, for example, if there's propionic aciduria, and then it steals the CoA from here to generate propionic CoA, what is the end result? The result, you do not make acetyl-CoA. So without acetyl-CoA, we are unable to generate this activator here, and therefore the enzyme will be rendered inactive. Okay, and because of that, you cannot detoxify ammonia. Okay, so that is why patients with propionic aciduria, they can have significant hyperammonemia. This is because they cannot detoxify ammonia, and they cannot start off the urea cycle. As I mentioned, OTC deficiency is the common disorder that we come across. So it occurs after the carbonyl phosphate has been formed. So this undergoes a pyrimidine synthesis pathway to generate of orotic acid, which is diagnostic of OTC deficiency. So, so this colored diagram here, this represents citrin. So citrin is there, it's a transporter. That's the first transporter in the urea cycle. So its deficiency will give you citrullinemia type 2. There's also another transporter that you need to know about, is the ORN, okay, transporter. This is important because if you have a deficiency of this transporter, we get what you call triple H syndrome. Triple H syndrome has got a long name. The long name is hyperammonemia, hyperomethemia, homocitrullinuria. So that is a triple H syndrome as a result of the transporter that is not being synthesized. So, as a recap, citrulline, it is very important to differentiate between the proximal and the distal. So the proximal will be OTC deficiency, CPS1 deficiency, and then everything that occurs after citrulline, or the blockers after citrulline, it will result in high citrulline, which are the citrullinemia, as well as agenosuccinic aciduria. Right. So this is a useful algorithm for hyperammonemia because it can be caused by various inborn errors of metabolism. So how do you go about investigating a baby or a unit with hyperammonemia? So you have to look at the age of onset of symptoms. If it's less than 24 hours of birth and the baby is preterm, then you have to think about transient hyperammonemia of the newborn. Okay, so essentially this means that the enzymes that involve the urea cycle, they are premature, so therefore they can't clear the ammonia. But very important is that transient hyperammonemia of the newborn is a diagnosis of exclusion. Okay, so you're supposed to exclude other more serious conditions before you can label the baby as having transient hyperammonemia of the newborn. Okay, and then if it's a term, it will go the same as more than 24 hours of the age of symptoms. So now you have to do a blood test. You have to check for urine ketones. If there's acidosis and ketosis present, then you think of organic acidemia or fatty acid oxidation disorder. So, and if there's no ketosis, there's no acidosis, then you think of the urea cycle defect. So urea cycle defect, they tend to cause respiratory alkalosis, but it is not always present. Okay, so basically you just want to see if there's no presence of acidosis or galactosis. Maybe the patient is alkalotic. Then you think of urea cycle effect. Plasma citrulline, very important, was differentiate the proximal and distal. So if the plasma citrulline is high and significantly high, then you think of citrullinemia type 1 or arginosuccinate synthase deficiency. And then if it's moderately elevated and then have arginosuccinic acid present, then you think of arginosuccinate lyase deficiency. So if the plasma citrulline is low, so it means what the problem is a proximal defects. Okay. Then the next investigation is the urine organic acid for orotic acid. If orotic acid is normal or is low, then it's CPS deficiency, and then if it's high, it's called TC deficiency. So that is all on urea cycle defects. The next disorders are fatty acid oxidation disorders. So before you get to the disorders, you need to understand the physiology of fatty acid oxidation. So you start off with the shuttle. Okay, the shuttle is called carnitine shuttle. Okay, so why is this important? It's important because long-chain fatty acids. Okay, long-chain fatty acids, they are impermeable to be transported into the inner mitochondrial membrane. Okay, this is the plasma membrane, outer mitochondrial membrane, inner mitochondrial membrane. So these long-chain fatty acids, it need to be taken in the membrane for beta oxidation. Okay, but unfortunately, the fatty acids or in the acyl form or with the CoA, this becomes impermeable to go into the inner mitochondrial membrane. So then, what needs to happen? It needs to be bound to a carnitine or a carnitine shuttle. So how does that happen? It's catalyzed by an enzyme called carnitine palmitoyl transferase 1. Okay, essentially what it does, it removes the CoA, and then the carnitine it gets bound to the fatty acid acyl group. Okay, so once it's bound to carnitine, then it becomes permeable. Then it's transported into the inner membrane. But then to start off the beta oxidation, you need to go back to the acyl CoA form. Then what happens? Got another enzyme similar. It's carnitine palmitoyl transferase 2. So essentially, what it frees the acyl group from the carnitine to be an acyl CoA to start off beta oxidation. And then the carnitine that gets freed here then is transported back into the outer membrane to collect more fatty acids, more long-chain fatty acids. So once it's inside, it needs to be broken down into the beta oxidation. Okay. So the first step of beta oxidation is a dehydrogenation step. So these are the enzymes. These are called acyl dehydrogenase. Okay, we can either get short chain, medium chain, very long chain, as well as long chain, depending on how long the fatty acid chain is. So from 2 to 4, we regard as short. So short chain acyl dehydrogenase we work on it. Medium chain is 6 to 10. Long chain is 12, and very long chain is more than 20. More than 20 carbon long fatty acids. So once the dehydrogenation takes place, then it's followed by a hydration step, oxidation step, then thyrolysis. So thyrolysis, I think, will be the most important one, because what happens here in this beta oxidation is to reduce the length of the fatty acid by 2. How do you do that? By removing acetyl CoA from the fatty acid. Okay, so as it goes through the process, it becomes 12 long, and then remove the acetyl CoA, then it becomes 10, and then it's repeated over and over again. So this acetyl CoA, as I mentioned before, goes to the Krebs cycle, respiratory chain, and that's how you generate much needed energy for the body. So these are the fatty acid oxidation disorders. I don't think it's important to know all of them or the various steps. Just to mention that the ones that we see commonly in South Africa, they are very long chain acyl-CoA dehydrogenase deficiency, as well as the medium chain acyl-CoA dehydrogenase deficiency. So these are the ones that we come across more commonly. So what is very important about fatty acid oxidation disorders is how they present, the clinical presentation. So what is critical about these disorders, they affect organs that are high energy demanding, okay, or high energy demands. So what are these organs? It's the brain, obviously. So it gives an encephalopathy. The liver gives an hepatopathy. The heart gives you cardiomyopathy, and also like the muscles. So these are the high energy demanding organs. So what is also important about these patients that they will tend to be asymptomatic or clinically well until they have a precipitant. So precipitant comes in the form of a stressor, or it's due to infection, due to surgery, or due to fever, or even starvation. Remember, during starvation, the body breaks down fatty acids to generate the energy. But if the fatty acid oxidation is already, it means you cannot break down the fat. Therefore, the patient will have hypoglycemia with no ketones. Why ketones? The process of ketogenesis, okay, is dependent on beta oxidation. Okay. So if you don't have beta oxidation, you cannot generate ketones. That's why this patient typically have hypoglycemia with no ketones. Remember that propionic acidemia gives hypoglycemia with ketosis. Very, very important distinction. So this is chromatogram of a medium chain acyl dehydrogenase deficiency, or an MCAT deficiency. So what you see here, this highlighted, or this metabolites that are in red here. So these are the typical ones that we get with medium chain acyl dehydrogenase deficiency. So what is important about this metabolite is that they are 6 to 10 um, 6 to 10 dicarboxylic acid dicarboxylic acid, which are 6 to 10 carbon in length. Okay, that is the typical chromatogram for MCAT deficiency, with those 6 to 10 carbon long dicarboxylic acid. So I've covered all the disorders now. So now we want to do investigations. How do you go about investigating a patient who suspect of inborn errors metabolism? Importantly, is the full blood count. Why full blood count? Remember that organic acidemias, they can suppress the bone marrow, okay, giving you a pancytopenia. So FBC is helpful in that regard. Urea tends to be low in urea cycle defects. Okay, remember, if we have urea cycle defects, we're not generating urea. So remember, you do urea as part of the kidney function test, is a routine test. So in some profiles where you see low urea, okay, it can also raise the alarm for a possible urea cycle defect. Hyperammonemia, we get it with fatty acid oxidation disorders, organic acidemias, as well as urea cycle defects. Lab glucose is very important because most of these present with hypoglycemia. Uric acid, remember I mentioned that GSD type 1, it results in hyperuricemia. Blood gas is very important for high anionic metabolic acidosis with organic acidemia, or respiratory alkalosis with urea cycle defect. Creatine kinase is also important when you're looking for metabolic myopathy, which can also occur with glycogen disease. And lactate pyruvate ratio, we also use it quite a lot, especially if a person has hyperlactatemia. So now you want to differentiate if it's because of a pyruvate dehydrogenase deficiency or because of respiratory chain disorders. Ketones I already mentioned, because you want to see if it's hypoglycemia, does it have ketosis or no ketones, because it gives an idea what if the person has fatty acid oxidation disorder or organic acidemias. Yeah, so now there are also these other investigations which are non-laboratory as such, or non-chemical pathology. So, for example, tissue biopsy. This is important because some of the patients with inborn errors of metabolism, Okay, the clinicians, they get they tend to investigate for this inborn errors of metabolism after the biopsy has indicated some findings which are suggestive of IEMs. So remember, IEMs are very rare. Some pediatricians don't know about them. So it's only when they do biopsy, tissue biopsy, that they can get the clue. Okay, and they get referred for to consider inborn errors of metabolism. For example, the liver is most important for storage diseases. Okay, so if you have lysosomal storage diseases, if you have glycogen storage diseases, the tissue biopsy can be able to show you with some specialized state that these patients will have a typical disorder, typical lysosomal or some storage diseases. CT scan and MRI brain, some reports that you've seen, they were highly suggestive of inborn errors of metabolism. For example, Tyrosine Pathway type 1, it's got very typical MRI findings, as well as childhood cerebral adrenoleukodystrophy, typical MRI findings, which then alert the doctors or the pediatrician to think of inborn errors of metabolism. So in terms of specialized investigations, so this is what the metabolic labs will do for you when you want to investigate for inborn errors of metabolism. So they use this highly technically demanding instruments, the GCMS, as well as the tandem mass spec. In most cases, it will be interlinked with the liquid chromatography. So what we'll be investigating for, or how do you investigate these patients? So you will request serum or urine amino acids. Okay. So here, if you are thinking of an aminoacidopathy, okay, and then urine organic acid, very, very important, because most of the inborn errors of metabolism can be able to be diagnosed with urine organic acids. Okay. The organic acidemias, some fatty acid oxidation disorders, even galactosemia. I've shown you chromatography galactosemia or the galactosemia chromatogram. So most of the urine organic acid analysis, they are able to make a diagnosis of most of IEM. So if you're investigating a patient for IEMs, your investigation is not complete without doing urine organic acid. So I always tell pediatricians that if you have to choose one test to investigate for inborn errors of metabolism, it has to be urine organic acid, because this is the one that's got a higher yield of diagnosing a higher number of disorders. But of note that it's mostly useful when a person is going through a metabolic crisis. So when the person is symptomatic at that stage, that is the perfect time to collect the urine. Other investigations, acyl carnitine profile. So mainly we use this for investigations of fatty acid oxidation disorders, but you can also use it for screening for organic acidemias. Okay, so for example, for propionic aciduria, what you get propionic carnitine, very specific for propionic aciduria. For long-chain fatty acids, this mainly we use for peroxisomal disorders. Okay, for example, the adrenoleukodystrophies. And then enzymes activity can also be useful, especially for galactosemia. We tend to measure the galactic activity to make a diagnosis. But to confirm the diagnosis, you need some molecular testing, because these are all genetic tests. So if you want to do genetic counseling for the parents, you need to have a specific mutation that can be detected by DNA testing or other molecular testing. Coming to management, so the most important thing that we need to be aware of is that inborn errors of metabolism, they are life-threatening. Okay, especially the intoxication ones. Okay, so the sooner you make a diagnosis, the better the chances of improving outcomes. Okay, so early detection saves lives. Okay, because once you make a diagnosis early, then you start treating by restricting the diet, then we are able to improve their mobility and even prevent mortality of these babies. So how do you go about management? You restrict the diet. Some of these patients, especially the intoxication type, they occur as a result of exposure to a certain diet, okay, or a certain metabolites in the diet. So that's why you need to restrict the diet, okay, to prevent further metabolites and further complications that arise from that specific organic acidemia. So once you restrict the diet, you give the patient IV dextrose. So this is important because you need to promote anabolism. Okay, some of these conditions they present because this catabolic state. So the one way of promoting anabolism is through IV dextrose because then it stimulates insulin production, which is an anabolic hormone. Carnitine supplementation is very important for organic acidemias because basically what it does, the carnitine binds to the propionic acid, for example, and then it makes it water soluble, and then it gets excreted in the urine. Okay, that's why it's very important to always give them carnitine. Vitamins, I already mentioned that metabolic acid, vitamin B12 responsive, or even a maple syrup. Remember that I said it's time independent. So some of these vitamins like biotin for preventing acidemia, they can also be very helpful in managing these patients. So NTBC is a drug that has been introduced to manage tyrosinemia type 1. I'll mention in a minute how does it work. So benzoate phenyl acid, these are called ammonia scavengers. Okay, so basically what they do, they bind specific amino acids in the blood, and because they bind them and they end up being excreted. So they bind them, make them water soluble, and excrete them. And because you're removing these amino acids, it means you're reducing the nitrogen pool. Okay, so therefore the ammonia gets to be reduced by this process. Very, very important, especially if someone has severe hyperammonemia. Dialysis also indicated, especially if the ammonia scavengers are not working, then the next mode of treatment is through dialysis. And dialysis is also very important in getting rid of that other metabolites that we can also that get increased with organic acidemias. So this is a tyrosine pathway again. So what I want to show you now is the effect of the NTBC drug, okay, or the nitisinone. So remember the dangerous metabolite tyrosinemia type 1 is this succinyl acetone. So what they've done, they've developed this drug. Okay, so this drug, what it does, it blocks the reaction that occurs upstream to where the condition is. Okay, so why it is important is that if you block this, okay, then it means you are generating less substrates or lowering the substrates that are ultimately leading to succinyl acetone. Okay, so because of this block, you generate less succinyl acetone, and therefore you are able to control the disease, tyrosinemia type 1. So this was a very important discovery because before the patients, before they discovered this drug, okay, the only way of treating tyrosinemia type 1 was by liver transplant. That was the only way. So really, this drug changed the way this condition gets managed, and then it has really improved the lifespan of these patients, as well as reducing that risk of developing hepatoma or hepatocellular carcinoma. So these are other miscellaneous diseases under ENs. So these are lysosomal storage diseases. So there are about 6 to 7 types of LSDs. Okay, so I'm just going to mention these two because especially this one, mucopolysaccharidosis, this is the one that we see commonly in our setting. We see type 2, there's about 8 types. Okay, so type 2, also known as Hunter's syndrome, is an X-linked disorder that's quite common among our population. So the case is the result of a mutation in the IDS gene, which reduces this enzyme, adenylyl 2 sulfatase. So basically, this enzyme, it initiates the degradation of glycose aminoglycans. Okay, these are complex carbohydrates or carbo, amino carbohydrate molecules in the lysosome. Okay, so if you are unable to degrade them, they accumulate in the lysosomes and then result in multi-organ involvement. So here it affects the heart, it affects the skin, it affects the skeletal muscle. So it's got multi-organ involvement. So how you make a diagnosis? You measure this glycosaminoglycans. Okay. So you measure dermatan and heparin sulfate, as well as the which is also confirmed by mutation in the IDS gene and undetectable enzyme activity. So another one is pump-based disease. So this one I already mentioned as a glycogen storage disease. Okay, but remember it also occurs as a result of the deficiency of this enzyme. It is also in the lysosome. So it also has lysosomal storage disease. So it tends to affect the heart as well as the muscles. Okay, the high energy demanding organs. So the reason I mentioned something about Hunter syndrome or mucopolysaccharidosis is because of this publication that was in the clinical chemistry, the genetic metabolic series. Okay, so here we had a patient with Hunter syndrome, but with severe cardiac lesion. So what stood out about this patient was that the severe cardiac problem that this patient had. So usually with Hunter syndrome, you only get conductivity problems, you only get valvular problems because of accumulation of the glycosaminoglycans in those in the valves or the conducting system of the heart. Okay, so this one was special because this patient had severe cardiac lesion. Okay, this patient has a large VSD, left pulmonary agenesis, which complicated into acidemia syndrome. The left lung was also hypoplastic because it was not getting blood from the pulmonary tract. So this is important because the leading cause of death in this patient is cardiac problems. Okay, so they have just mentioned that the cardiac lesions, they can also be very severe with Hunter syndrome or mucopolysaccharidosis type 2. Another important aspect of lysosomal storage disease is how they can respond very well to ERT. Okay, ERT is enzyme replacement therapy. Okay, so these are two patients with Gaucher disease. Okay, which is mainly found in the eastern countries. But what is also important about this patient is that they have accumulation of these metabolites, the glucocerebrides in the spleen and in the liver. Okay, resulting in massive hepatosplenomegaly. But what happens is that when you give them the enzyme replacement therapy, what happens is that it breaks down all those metabolites and the patients make a quick recovery. So that is typical of how LSDs are managed. And also very important just to know that Gaucher disease can also cause multiple myeloma. So if you see a young patient with multiple myeloma, then you also think about Gaucher disease. So this is just a useful resource that I thought I should share with you. This goes with the electronic kits textbook that we use for chemical pathology. So right there at the end of the book, chapter there at the end, is this kit atlas of biochemical genetics. Okay, so this chapter contains cases of inborn errors of metabolism. So here is an example. So what it does is that by giving you clinical history and background. So this is a patient with classic kind stroke, hypoxic breath dystonias, and spasms, and then it's followed by a chromatogram. And chromatogram, then you can see that is glutaric acid, glutaconic acid, as well as 3 hydroxyglutaric acid that have been found in high amount. So, and obviously from this, then you make a diagnosis of glutaric aciduria type 1. So next in the book, it tells you about the pathway. Okay, so it tells about where the enzyme deficiency is. So this is a gluteryl-CoA dehydrogenase enzyme, which catalyzes the reaction there. And then if you have the enzyme block there, then we have accumulation of this metabolite there. So and then it's also followed by a diagnosis as well as a case discussion. So it tells you about the condition there, the enzyme there, and then also the clinical presentation, how you treat it, and so on. So what is important about this condition is that we see it commonly in South Africa, especially in the Black African population, due to a specific mutation that we see. So of note is that this condition is often misdiagnosed as a babies with shaken baby syndrome. Okay, this is because of the MRI findings that we get. So if we do imaging, the imaging is typical of a baby that has shaken baby syndrome. Okay, and when shaken baby syndrome is a form of child abuse. So there have been parents that have been wrongly persecuted as a result of this MRI findings, only to find that there was actually a misdiagnosis. The patient suffered from glutaric aciduria type 1. Very important condition. So this will be the end of the lecture. So I just want to acknowledge the laboratories that are involved with the investigations of IEMs in South Africa. So we have the NHLS, done at the Red Cross Metabolic Lab is at the University of Cape Town. So they cater for the public sector. And you also have the Center for Human Metabolomics. This is Potchefstroom Laboratory for Inborn Errors of Metabolism, or PLIM. So at Northwest University, so they cater more for the private sector. So some of the chromatograms that I shared with you, they come from this. Metabolic labs that do a stunning job for us in the country. So that will be it. So these are the resources that I used mainly for this lecture. So you can also go through them for further information or for more details with regards to the inborn errors of metabolism. So thank you for the opportunity, and I do apologize that the lecture has been too long, but I just wanted to make it as comprehensive as possible to be able to appreciate the inborn errors of metabolism. And thank you for your attention.